So now that we understand the why and what of EKGs, let's look at how we interpret them. So here are some key points to remind yourself of as we learn about interpreting EKGs. We don't want to get so caught up in labeling the dysrhythmia that we forget about the patient experiencing the dysrhythmia. Remember to think about how that rhythm must be affecting the patient. We have this electrical activity in our heart so that it pumps. So how is this dysrhythmia affecting that pump? How is it affecting our stroke volume and our cardiac output? So some of the first signs we'll see in a decrease in cardiac output are changes in the patient's neurological status. Maybe their level of consciousness or their activity level. Maybe they used to get up to walk to the bathroom, but now they're too tired. We might see changes in vital signs. For instance, if somebody's EKG is so dysrhythmic and so severe that their cardiac output reduces dramatically, you could definitely see their blood pressure drop. So what else? What's your job as the nurse? Let's say you've just interpreted an EKG and identified the dysrhythmia correctly, but what's next? Is the patient stable? Do we just need to monitor them, or is this an emergency or a significant change that requires a call to the physician? So during this process, you should be thinking about why this dysrhythmia occurred and as well, what can be done to correct it. So as we look into interpreting EKGs, we need to get familiar with the EKG paper. Notice that the vertical axis is the amount of voltage and the horizontal axis is time, and that's mostly where our focus is. So be sure you remember how many small boxes and larger boxes equate to how many seconds, which is in red here. Here we have a quick review of the normal time intervals for EKG complexes. While there are a number of segments to measure, notice that the PR interval and the QRS intervals are absolutely necessary when interpreting a rhythm strip. The other important interval to note is the QT interval. Now, the QT interval will not determine the EKG rhythm, but a prolonged QT interval can be dangerous and potentially trigger a lethal rhythm such as ventricular tachycardia. So you might recall that certain drugs, such as haloperidol, can potentially prolong the QT interval. So it's important that you measure this as the nurse caring for a patient on telemetry monitoring. So now that we know the correct intervals for the parts of the EKG complex, let's remember what each part of the complex represents. So remember, the vertical axis in this tracing is voltage. So a high peak means lots of voltage. A smaller bump means less voltage. And typically, a bigger part of the heart is going to have a lot more voltage when it's depolarizing than a smaller part of the heart. So beginning with our P wave, the P wave is representing atrial depolarization. The atria are going to contract. So remembering our cardiac cycle, who started this atrial depolarization? It's the SA node. So in a sense, you can see the P wave as the SA node's signature, for instance, for triggering an atrial contraction. Next, after the P wave, we flatline. There's no electricity, we're just waiting. And this is that pause at the AV node that you might remember. So a normal heart should have this flat pause representing that moment when the AV node slows electricity down and pauses everything. Next, we see a big QRS complex. This big amount of electricity is representing the biggest part of our heart depolarizing, the ventricles. And see how much bigger it is than our little P wave, our atrial depolarization? So remember, this is an amount of voltage. It's also happening fairly quickly. It's less than 0.12 seconds if you remember our intervals correctly. So this is a big electrical force, but it's also an efficient electrical force so that the ventricles can squeeze the blood out efficiently. And then last we have the ventricular repolarization period, that long, slow T wave. So some takeaways here. Remember, if you look at an EKG strip and you see problems with the P wave, you've got an atrial problem. If you can't identify what it is exactly, that's not your first step, right? You're looking to see if there's something wrong with my P wave, the problem's in the atria. If I look at an EKG strip and I see problems with the QRS complex, maybe I don't know exactly what the problem is, but I know there's something wrong with my QRS complex. Now I need to focus on my ventricles. I have a ventricular problem. And if my P wave looks okay, but there's a problem with that PR interval, the problem with that flat line area, now I've got an AV node problem. So remembering that P wave is atria, QRS is ventricle, and the PR interval is AV, that can really help you when you're looking at an EKG strip and trying to identify, okay, where should my focus be, the atria, ventricles, or AV node? So the first step in interpreting an EKG strip is reviewing the rate and rhythm. The rate is determined by counting the number of R waves in a 6-second strip and then multiplying that by 10. So here in this 6-second strip we have 7 R waves, so the patient's heart rate is 70. Next we want to know what the rhythm is. Is the beat regular or irregular? Here we use calipers or marks on a piece of paper and determine the distance between 2 R waves and then march that distance out to all the other spaces between R waves, or the R to R distance, to see if it's the same. If the spaces between all of the R waves are very similar, so within 1 to 2 tiny boxes of each other, then the rate is regular. If you find that as you march out the calipers, the other R to R ratios are very different, you now have an irregular rate. Therefore, it's important to check all of the R to R spaces for the entire strip. Beginning with normal sinus rhythm, this is basically the ideal EKG strip. There's nothing wrong, everything is looking as it should. So how should an ideal EKG strip look? Well, you should have a normal, uniform P wave throughout the strip. And here you can see an example up top of what different P waves would look like. So this would not be normal sinus rhythm. And then below, normal P waves that look fairly consistently shaped. Just recognize they're not going to look identical, but they should look consistent. The strip should also have 1 P wave before every QRS complex. Note that I say every QRS complex, so you should be checking every P wave precedes 1 QRS complex, and there is only 1 P wave to 1 QRS complex. Then last, you'll measure your PR intervals and your QRS intervals, and those should fall within the normal ranges. The only difference between sinus rhythm, sinus bradycardia, and sinus tachycardia is the rate. So you can see here what the heart rate parameters are for each of those. So next we have what's called atrial fibrillation, and essentially what's going on here is the atria, those upper chambers, are quivering. There are multiple ectopic foci firing away in a disorganized fashion. And note that this atrial defibrillation is going to involve the upper chamber. So remember, anytime we're talking about an atrial dysrhythmia, we're talking about which part of the PQRST complex. It's the P wave. So therefore, because this is an atrial problem, our QRS should actually look normal if you just look at the QRS interval itself. It should be less than 0.12 seconds. It's the P wave and really the PR interval gets affected when we're talking about atrial problems. So what does that quivering atria look like? It's a quivering baseline. It's quivering lines between the QRSs. So we don't really have P waves anymore. The SA node is no longer in control. So instead, we have a whole bunch of ectopic foci firing away, and this translates into a chaotic, squiggly baseline. We can't find a P wave. There actually are way too many little waves in there to discern really what's going on, but we do know that it's chaos. So because the SA node is normally in control and gives us a nice regular rate, we now have chaos in charge. So what does that translate to? No more regular ventricular rate. The AV node will try to slow down this chaos going on up in the atria, and they'll try to keep the ventricles responding at a controlled rate, but this doesn't always happen. And this is why atrial fibrillation can be so dangerous. It's all about our ventricular response rate. How are the ventricles responding to these crazy fibrillating atria? So controlled ventricular response would give us a rate of less than 100 ventricular beats per minute, but an uncontrolled response, sometimes what we call rapid ventricular response or RVR, gives us a rate of over 100. But the bottom line is that the ventricle response will be irregular because a chaotic atrial rhythm will not cause a regular ventricular rhythm. So your key takeaways here should be, if you want to identify atrial fibrillation, you're going to see that there are no P waves, just a chaotic squiggly baseline, and there's irregular R to R ratios, but your QRSs are still skinny and normal, that less than 0.12 seconds. Now, atrial flutter is slightly different than our atrial fibrillation. The SA node is still not in charge and still not triggering our cardiac cycle, but we don't have the chaos we saw before with atrial fibrillation. So rather than having multiple ectopic foci causing electrical chaos in the atria, we have one ectopic focus in the atria, and that one focus has decided to trigger the cardiac cycle. Now, this ectopic focus was not supposed to be the pacemaker, and it's actually starting the heart at a very fast rate. and it begins to cause the atria to depolarize very quickly, sometimes around 200 to over 300 times a minute. So again, we have a problem in the atria. They aren't quivering anymore, but they are contracting very quickly. And we call these quick atrial beats caused by that one single ectopic focus F waves. And they typically look like taller bumps, or what we call a sawtooth pattern. So once this ectopic focus sends this really fast signal down to the AV node, what does the AV node do? Well, it does the same thing it tried to do with atrial fibrillation. It wants to slow down all of these crazy F waves and not let them get through. Because if they did go through to our ventricles, they would be beating at 200 to 300 beats per minute as well. So the AV node will try to stop every couple of F waves to try and slow things down for the ventricles. However, this can still cause a pretty fast ventricular rate. So with atrial flutter, your key signs are this sawtooth pattern of F waves instead of P waves, and a ventricular response to those F waves. And the F waves look very similar to each other because instead of chaos in the atria and all of those crazy different bumps, we have one ectopic focus generating one signal from the same place. So the same signal from the same place is going to look the same in the EKG. Now, depending on how well the AV node can slow down those F waves, we'll see different ratios. So sometimes 2 F waves will lead to 1 QRS. Sometimes we'll have 4 or 5 F waves to 1 QRS. And sometimes it's going to vary. So you'll have 2 to 1 1 second, and then 4 to 1 the next. So if the ratio is always the same, 2 F waves to 1 QRS, let's say, the heart rate will be regular. If it varies though, so you have 2 to 1, then 3 to 1, then 2 to 1, then 5 to 1, etc., our ventricular rate will be irregular. But again, our main concern is our ventricular response. A very fast heart rate can be dangerous and ineffective. So your main takeaways are that this is an atrial problem, so we won't have P waves and we will have F waves instead. And our QRS will still be within the normal limits, less than 0.12 seconds, because we don't have a problem in the ventricles. We have a problem with ventricular response. So our ventricular response might be regular or irregular, but likely very fast. So here you can see the difference between atrial fibrillation and atrial flutter. Neither one has P waves, but if you look at the top strip, this one has a chaotic baseline caused by that quivering atria, and the bottom strip has very consistently shaped F waves caused by that one ectopic focus in the atria. So notice our atrial rate in atrial flutter. The frequency of those F waves is very, very fast, and in this atrial flutter example, our AV node managed to control that ventricular response to that rate pretty well and pretty consistently. And actually, if you look, both of our AFib and A-flutter examples here are what we would call controlled, because the heart rate, when you count those R waves, is less than 100. So one category of atrial dysrhythmias that's really important to discuss is called SVT, or supraventricular tachycardia. Now break down that word for a second. Supra means above, ventricular means ventricles, and tachycardia means fast heart rate. So in a sense, this term means anything above the ventricles causing a fast heart rate. And therefore that anything could mean AFib, atrial flutter, sinus tachycardia, etc. But something in the atria, something above the ventricles, is causing a fast heart rate. But it's so fast, it's above 150 beats per minute, that we actually can't figure out what's going on between those QRSs. Is there a P wave? Is there an F wave? Is there maybe even a hidden chaotic baseline between those QRSs? We don't know. And now because it's an atrial problem, our QRSs are actually still narrow. They're normal, less than 0.12 seconds. They're just happening very quickly because the atria are misbehaving and their rate is above 150 beats per minute. So here we have 2 different strips, and these are both fast heart rates. These are 2 tachycardias. And in looking at the top one, I can see that there are P waves, and they're all roughly the same. There's 1 P wave to each QRS. My QRS complexes are less than 0.12 seconds, so those are normal. So everything looks normal here except the rate. So this is a sinus rhythm, but because it's fast and my rate is 110 beats per minute, this is sinus tachycardia. Now, when we move down to the second strip, I can't tell if that spike between the QRS complexes is a T wave or a P wave. Maybe it's an F wave. Maybe there's some chaos going on in there, but I just can't see it. And this is a good reminder of why it's important to understand our EKGs are showing us a summation of activity. So there could be some hidden atrial fibrillation going on there, but I can't see it because the ventricles are beating so fast that there's more electricity in the ventricles than in the little atrial fibrillation that could be hiding. So the rate for this strip, when I look at the ventricular rate, it's 180 beats per minute. There's 18 R waves here. And it's too fast to figure out what's causing it. But I do know that the atria are at fault because by process of elimination and looking at my QRSs, those are normal. They're less than 0.12 seconds. So I would call this a supraventricular tachycardia. So this covers our atrial dysrhythmias. Please review the presentations on junctional, ventricular, and lethal dysrhythmias.